Hello and welcome to our tips and tricks video for the Linton, Minnesota and Blakemore tube. Now this is less about the anatomy or makeup and structure of these tubes, which can be confusing. For more on that, check out our prior video, the Linton, Minnesota and Blakemore tube demystified, link of which you can see below. This is going to be a video about how to get these tubes in place in a patient. Putting them in physically, getting them in the patient's esophagus down into the stomach and seated right is very challenging. We have 4 tips we're going to review today on how to do this in an incremental way. Let's dive in. First, let's recognize that we have all tubes: the Linton, the Minnesota in the middle, and the Blakemore. We even have a pediatric Blakemore, but that is a special kind of terrifying that we'll save for another day. Now, briefly in the anatomy of these, we recognize the Linton is the tube with just a gastric balloon, no esophageal, a single insufflation port, 2 aspiration ports. Again, the details of that you'll see in our former video. Next, we see here the Minnesota tube with all of its craziness up top. It has a gastric balloon, an esophageal balloon, aspiration ports for the esophagus, and aspiration ports for the stomach. Finally, we have probably the most common, which is the Blakemore tube. It has the gastric balloon, the esophageal balloon, aspiration port below the gastric balloon, and no esophageal aspiration fenestrations. Now, the first tip or trick we really want to highlight is the use of the stopcock and luer lock system. We have them in place here. Taking them down, you can see we have a 3-way stopcock and a luer lock. One luer lock on a channel and an open channel. One of these small openings, as you'll see here, will be fed over the insufflation port for the gastric balloon, and a separate setup will be put in place for the esophageal balloon. One on each. One closed channel, so when you put air in, it can't escape through that luer lock, and one open channel. When you open the stopcock, you can get air out. This is really nice in that, again, you can see our provider insufflating air here into the gastric balloon. They twist it off and they don't have to worry about clamping or unclamping a tube. The other really nice thing about this system is it allows you to instill your 50 cc aliquots of air really rapidly. So by having the channel open to the room, you can pull in air, you switch your plunger to your insufflation port, and you put in your 50 cc's. You switch back, pull in air, switch to the port, put in 50 cc's, back and forth, back and forth. You can really easily put in the entire quantity of air here without having to clamp and unclamp, to twist and untwist from the luer lock system. It's a really pretty slick way to get your air in. Highly recommended for all. By simply swinging the stopcock so that the port is open to the non-luer lock channel, the air will drain out of your balloons, as you see with the gastric balloon here. Okay, as we prepare ourselves to talk about the 4 tricks for inserting the Blakemore tube or the other types of tubes, the first thing we're going to do is get ourselves set like we are going to test our balloon integrity, right? This is one of our first steps before inserting a gastroesophageal balloon tamponade device. We have to make sure that the balloons have no holes. So we put it in a basin of water, we inflate the balloons as you can see here, dunk them underwater, and make sure there is no air leak, no air bubbles. Pretty sophisticated way to test the integrity of the balloons. If you have 2 balloons, a gastric and an esophageal, you're going to test both, like we're doing here with our Blakemore tube. Okay, our balloon integrity seems to be confirmed. Now, before we dive into that first trick, one other really important thing that I highlight when teaching this procedure. After you check your balloon integrity, you want to fully deflate the balloons. Simply opening up the stopcock and squeezing them out like we're doing here is a start, but that actually still leaves some residual air. So what you'll see our practitioner do here is, again, use our luer lock system and suck with our large volume syringe all of the air out of our gastric balloon, and see how much more tightly we can get that excess material down in size We really want to squish this down to decrease the amount of drag we're going to have. A nicely squished down gastric balloon there. We are going to repeat that process, of course, with our esophageal balloon if your device has one. Now, I might be a little nitpicky here, but you'll notice that the balloon material is not evenly distributed around the catheter, and I want to have the least amount of drag going through the esophagus as possible. So I actually put a little bit of air back into the balloon, move the catheter into the center, and then suck all of the air as much as possible, like vacuum seal that balloon onto the catheter there. We pull it out and we even do it again just to make sure any residual air is out and the balloon as decompressed as possible. And as you can see here on profile, that balloon is very thin, the least amount of drag possible. Okay, with our balloons tested and fully deflated, we put them into our basin and we're ready for trick number 1. Now we do these tricks in incremental order from easiest to probably most complex. Keeping our Blakemore in our balloon testing basin, we are simply going to dump in a whole bunch of ice. While we are preparing everything else related to the patient and the procedure, we are going to want the tube to sit on ice to stiffen up for insertion. Okay, so while our Blakemore is in the cooler, getting nice and chilled and stiffened, we can talk about trick number 2, which is to use your laryngoscope. These patients are incredibly ill, their airway is likely compromised, and they are probably intubated. In those circumstances, you probably have a dirty or used laryngoscope blade sitting around. Break it back out, or in this circumstance, it's okay to open a new blade to insert into the mouth, to move the tongue out of the way, to open the hypopharynx and give you a straighter shot down the esophagus. Okay, so on to trick number 3, and that is to break out your McGill forceps to get the trajectory of force in the right plane and to help try avoiding the coiling that can often happen when trying to get these devices down the hypopharynx and into the esophagus. Combining your laryngoscope blade with your McGill forceps can really give you a nice angle and trajectory down the esophagus and into the stomach. Okay, so on to our 4th and final trick for getting these pesky Blakemores to seed down into the stomach and esophagus, and that is to use an endoscopic biopsy forceps. Now, this is not something that you will have stocked in your department. This is the 4th trick. I would start with all of these other 3, but getting these devices down can be so challenging that I would actually recommend, while using these other 3 techniques, have a tech or other person go to the endoscopy suite and get this as your failsafe. What is this device? As you can see here, it is an incredibly long wired device with a tip used for biopsying the stomach, esophagus, intestines, etc. That is not the way we're going to be using it, but that is what it's designed for. Now, as you can see here, it's very important to be aware that this end opens and closes through control on the other side, which allows for small biopsies to be done in endoscopy. That is not what we will be using for, of course. We are using it as a semi-rigid introducer, essentially to stiffen up our Blakemore, Linton, or Minnesota. So as you can see here on our Blakemore, we're finding the gastric aspiration port. We are taking our endoscopic biopsy forceps, and we are sliding them down that port. Now we want to lubricate this as we go down, because we want the biopsy forceps to come out smoothly when we remove them, leaving the Blakemore all the way seated down in the stomach. So lubricate as you go down, or as you can see here, the practitioner puts a little reservoir of lubricant at the aspiration port mouth. Now we continue to seat it down, and as you'll see here, there are 3 side fenestrations for aspiration in the gastric area on the Blakemore. There is no terminal aspiration hole, or it is a blind ending tube, which is great. We can just seed our biopsy forceps all the way down, make sure that they're not coming out of these side fenestrations until it's fully seated at the base of the Blakemore. And that is it. You've essentially added a stylet to your Blakemore, Linton, or Minnesota tube. Now there's a lot of extra biopsy forceps you can see there. That's not important. You can now just place your tube down and in. And look at how much more rigid it is. It still is compliant, still has some movement to it, but much less floppy, much easier to get down and into the stomach. So in summary, we have 4 different tricks, and there are varying degrees of involvement in materials. First, as you can see, is putting the Blakemore tube, the Linton tube, the Minnesota on ice while you're getting everything else ready. You should be doing that pretty universally. Second is to use your laryngoscope to guide the Blakemore tube down. Third is to grab your McGills. And fourth, if needed, is to use your endoscopic biopsy forceps. Okay, we're going to conclude with a quick demonstration of using these biopsy forceps with a Blakemore tube on our model used in teaching gastroesophageal balloon tamponade. While doing this demonstration, it is of course important to offer a little bit of a disclaimer or a warning. We are definitely using a medical device in this circumstance not for the manufacturer's intended purpose. By using the biopsy forceps as a somewhat of a stylet, making the tube firmer, there's definitely the potential, though I would imagine relatively small, of using too much force and inducing further bleeding. That of course needs to be balanced against the fact that you can simply fail because of mechanics and drag to place a Linton, Minnesota, or Blakemore tube down into the stomach even after you've pulled out all your other stops. Having this in your back pocket is a nice fail-safe, but recognize that it comes with its own risks. With all this said, again, these patients are sick as stink. They are on death's door. I personally imagine pulling out all the stops, and if I'm having trouble seating the tube, I think using this device gently, making sure it's seated well and not applying too much force, is a fantastic way to succeed in a very challenging procedure.